A little bit about CoreNet before we begin. CoreNet started in May 2020. It's a research network. It's a community of practice which was built to foster exchange and collaboration among research organizations across the country that were working on COVID-19, and really became a community of practice that brought together learnings, not just on everything that was found as socioeconomic impacts of the pandemic, but also a community that was able to reflect on how practice itself or research methods, etc., needed to change as a consequence of the pandemic. Over the past year, we've had about 60 plus organizations that are part of this community. There's over 200 members that informally join us on Slack, where we exchange information, share messages, etc. We also have a web repository, www.corenet.in, where every member has submitted different research projects that are ongoing or completed with small metadata where you can just get a sense of what sort of research is happening. So you can already have a look at that. We've also been doing weekly and fortnightly events, which are coffee hours, which are community-only events such as this one, but also larger public events around ethics called Ethics Dialogues. And then we did this big conference called the CoreNet Conference through April and May, which was, again, 8 public plenaries on different sessions with researchers as well as external experts, as well as showcases from members and 4 dialogues. We also have 2 working groups, one on nutrition and another one on frontline workers. A little bit about the coffee hour format. This is, again, slightly longer because there is quite a bit that we have in store for you today. These are meant to be internal, sort of informal conversations, really to seed exchange among members, and also very much a co-created agenda. So in case if you have ideas for something you want to share with the community or have something to discuss, we'd be more than happy to curate a coffee hour for you. So with that, I'll briefly sort of introduce the agenda for today, and then we can move on. For today, after the introductions, which I just finished, we have 3 intro presentations from NCAER, Final Mile, and SEWA Bharat, who will share a little bit about their studies in terms of their methodologies and findings. And then we have the Center for Social and Behavioural Change, who will share a crisp insight or a synthesis of these studies. Following that, we have a round of question and answers, and then we go to Prayogshala, who's already doing a study and has a proposition in case if there are other members who'd like to contribute with either their cohorts or other kind of support. So we have about 20 minutes for that. And finally, we hear from DataMeet on their sort of ongoing study on vaccine cost. So yeah, very excited to be doing this with all of you. Right, I will just pass on to Shantanu from NCAER.
Hello, good afternoon all. So let me directly so I'll be talking about vaccine hesitancy. Basically some findings from the Facebook COVID symptom survey data. So before we do that, so this is the current status of vaccination in India. So the vaccination campaign has really picked up starting phase 3, which is April 1. But after that, there's a sort of drop in the vaccination rate. I mean, it could be because of supply shortage or lockdown. So it could be multiple factors behind that. And gradually it has again picked up. But it's still, the rate is much lower than what we needed in order to achieve the target that the government announced, the target of vaccinating 30 crore people, so which is essentially 600 million doses by 31st July, I think. So that may require more than 6 million per day. So now we are doing around 4 million per day. And I mean, there could be multiple reasons behind the suboptimal coverage. And I mean, there could be supply side issues as well as demand side factors. Side issues mainly include the vaccine shortage and number of vaccination sites and lack of adequate trained staff to vaccinate. And of course, the digital registration system, which in itself can be an hindrance to coverage. But now I think we are getting more and more flexible in terms of allowing registration at the vaccination center. And pricing is also could be an issue, but I think government has again revised their the policy that as opposed to 50% free and 50% private, now they have revised it to 70%, 75% free and 25% private. So that's a very good step towards equitable coverage, I would say. And then, of course, even with the availability of free vaccines and no supply side issues, still there may be lack of willingness to get vaccinated. So that's essentially the the vaccine hesitancy part. And now coming back to the findings from this data, the Facebook COVID-19 symptom survey data. So the question that is asked, and this question has been included in the survey starting December 21. So this findings is based on data from December 21 till June 10. So if a vaccine to prevent COVID-19 were made available to you, would you be willing to get vaccinated? So there are four options. Yes, definitely. Yes, probably. No, probably not. No, definitely not. So we define hesitancy based on the last two responses, that is no, probably not, and no, definitely not. And in doing so, in defining the rate, we have excluded the population who are vaccinated. So one can argue that they are vaccinated, that means they are willing to take vaccine. So they should come in the denominator, but we have excluded them from the denominator with the rationale that we want to know hesitancy among the unvaccinated population. So that's why they have been excluded. And based on the combined data, it shows that the hesitancy level is much higher, significantly higher in Tamil Nadu and Punjab compared to other states. And Kerala and Odisha are one of the low hesitant states. But as Anushka will talk about, I think later, that, I mean, it's a dynamic process, how hesitancy changes because of the dynamic situation of the pandemic and related issues. So it's important to have a look at the temporal trend. And if we look at that, first Tamil Nadu, I mean, only recently for the last 1 month or so, there is a declining trend compared to what we have seen in the first 5 months. It was constant around 40% in the first 4 or 5 months, but only recently there is a declining trend, which is a very good sign. And some states there is a very steady declining trend, which is good, like Delhi, Maharashtra, Karnataka, etc. But some states there seems to be increasing trend also after wave 2 is over, which is a sign of concern. Like Punjab, you see, and also even Chhattisgarh, which was doing very good in terms of vaccination coverage, but now there seem to be an increasing trend there. Yeah, so and these are the weekly estimates we have plotted here. So each point is a weekly estimate of vaccine hesitancy. So these are some of the reasons behind hesitancy. So they were asked which of the following are reasons that you wouldn't take vaccine. So concern of side effects seem to be the major concern. I mean, here the survey has certain limitations. There's no way to distinguish between whether it's what do we mean by side effects. So it could be serious side effects, serious adverse events, or it can also include minor side effects. So that way it's not very conclusive. But anyway, so if side effects is a concern, there needs to be definite strategy to handle that. And I think use of AEFI data and the transparency around that might be a good strategy, which is completely lacking, I feel, at this point. So now the hesitancy, how it is associated with coverage. So you see in Tamil Nadu, we have seen that they have higher level of hesitancy and their vaccination coverage. So these are district level vaccination coverage of first dose and 2 doses, 1 dose and 2 doses. So you see in Tamil Nadu, most of the districts there, even 1 dose coverage is much below than 10%. So which kind of suggests that the hesitancy could be a reason behind the low coverage in Tamil Nadu. So here some findings based on the demographics. So these are the age groups. So for the older age group, we see an increasing trend among the unvaccinated population. So it could be that this is the population. I mean, most of them are already vaccinated. So the remaining population may not want to get vaccinated for whatever reason, could be health reasons, etc. And also there seemed to be an association with this second wave. I mean, after second wave, there seemed to be an increasing trend that we have seen in some states also. So this is by gender, and for female, initially there was an increasing trend, and then it steadily declined for a few months, and then now again after second wave we can see that there's a potential of increasing vaccine. So I mean, we all would agree that there needs to be more effective communication and transparency, and that was not there from the beginning. I think that initially the focus was entirely on managing the supply side issues and managing the logistics, but not necessarily on the vaccine hesitancy to mitigate strategies around vaccine hesitancy was kind of missing. So yeah, so I think the AEFI, as I mentioned earlier, it's more use of AEFI data could be useful, because all we get to hear about stories from our own circle, so there could be small sample bias there. So we can tackle that by using more and more AEFI data to show that there are very few cases of adverse events related to vaccination.
Great, thanks, Shantanu. Over to Anushka Ashok from Final Mile to share with us about their study.
So hi everyone, I'm Anushka. I'm going to talk to you about a study that we've done. This is more of a qualitative study. Of course, the aim of the research was to identify the conscious and non-conscious drivers for hesitancy and refusal of the COVID-19 vaccine, and identify levers for behavior change. So this is a purely qualitative study, which was done through remote in-depth interviews of 60 minutes, where we used certain decision simulations. And this was done only with a vaccine hesitant population that was identified through a survey. And in this interview, we went into the COVID context, beliefs and mental models, vaccination behavior overall, and then specifically decision about the COVID-19 vaccine. So the sample over here was 40. The research was conducted firstly in Jan. Out of the 40, there were 32 end users, and these were end users between the age of 18 to 70 across semi-urban, urban, rural, representing the 4 regions. And we did also go to end providers, which are ASHA workers, doctors, nurses, to understand their perception hesitancy and their understanding also of hesitancy in the population as well. But this was done in Jan. But later on, we also conducted another leg of qualitative research across a sample of 25 in rural urban Nagpur and in Punjab, Batinda, Faridpur, rural and urban with vaccine hesitant populations. And this study was done in the second wave. So I think at an overall level, some important research findings is that the decision to take the COVID vaccine is an active decision that needs to be made. And this decision is actually made in a very dynamic context, right? So the time in which you do the research, there is a certain prevailing context of caseload, of the news, which all impacts how a person is going to decide to take the vaccine. And in most cases, there's always a suboptimal assessment of risk perception for themselves. So even if there's low risk perception, they feel like they don't need the vaccine because they're doing enough. If there's high risk perception, they might consider the vaccine as too risky and think that compliance measures such as social distancing, masking, and staying at home is enough to keep themselves safe. Right? So there's this dynamic context we need to factor in. The second aspect that is important to consider is this mental model that people actually have, because what we saw is that overall people in India have a pro-vaccine attitude that comes from a very strong mental model around child vaccination, right? Everyone gets their child vaccinated, and it is something that is done without any consideration almost right now. But when you look at adult vaccinations in India, there's no mental model, because you never take a vaccine as an adult unless it is for something like tetanus, which is usually post-exposure. And also with the information coming out in the second wave about remdesivir injections, people seem to be confusing what the vaccine is. Is it more of a treatment, or is it protection or prevention? And even if they understand prevention, is it full prevention or partial prevention? Because they're hearing stories of people actually getting COVID after taking the vaccine, which is leading to an expectation discrepancy. And the last one is that when you're looking at a vaccine trade-off itself as a person is making, right? So I'm thinking about the fact that it's not only the risk and rewards about taking the vaccine, but it's also about the risk and rewards of staying as I am, continuing my behavior of not getting vaccinated, right? Because taking a vaccination is taking an action that disrupts the normal. So when I see the risk and reward of taking the vaccine is really high, and the risk and reward of me not taking the vaccine actually is a lot more favorable, right? Because we're overestimating our ability to manage the illness, to basically keep ourselves safe, and overestimating the ability of the side effects going to impact us and potentially kill us as well. And now you have a lot more stories, very vivid stories of side effects, as well as of adverse events from vaccines, so people rather stay away. So inaction is favored, which is why in this vaccine hesitant population, it is a trade-off that is weighted towards inaction. So what we've actually found in our research is the fact that hesitancy is obviously a continuum, right? And even within this continuum of hesitancy, we see actually different emotional personas, which have different barriers towards these vaccines, which are quite different, right? So you have certain people on the lowest end, which are basically confused or nervous because they look at the vaccines as unfamiliar, and therefore they know the vaccine is something they should take, but they're really scared about the implications on themselves. They're not able to understand what it means for them. And therefore, what we need to do to help these is obviously to make to kind of push them to take the vaccination, make it more of an opt-out default, really externalize accountability to a doctor that they can kind of ask, and also create an expectation, the fact that side effects are good and it means that the vaccine is working and they're controllable and you can cope with it and the vaccines are safe overall. The second segment is complacent. These people actually view the vaccines as dispensable because they feel like with all the measures that they're taking to keep their family safe and themselves safe, they feel like the vaccine is a costly alternative, right? It feels like something that is going to remove control because of the adverse events. I'm taking as much control in my household doing all these things. I don't need to do the vaccine as well. I'll do it later, right? So they're delaying the decision. So over here, it's about leveraging the self-image of being smart and compliant and almost like adding vaccine to your way of protecting yourself and talking about communication about vaccine, about gaining control over your life because it's about controlling the pandemic, as well as increasing the cost of not getting vaccinated, right? Because they're procrastinators. Both of these actually have a higher risk perception. On the other end of the spectrum, we have people who are indifferent. So these people actually don't feel like they need the vaccine because they feel that they're young, they're healthy, they have high immunity. And there are a lot of narratives around us that also feed into this immunity idea, right? I'm safe, I'm okay. The vaccine is actually for all the other people who are higher risk, right? So they don't account for the fact that they could be a carrier, and therefore it's important to change the focus of self into others and use a sense of social responsibility for their own in-group, right? And also, again, increase the cost of not getting vaccinated, like it's more costly for you if you don't get vaccinated when you're going to work, etc. So therefore, we'll get the indifferent category. And the last is the skeptical. So the skeptical is basically people who come from a space of COVID doesn't exist, or it is a conspiracy, or the fact that maybe it's a manufacturer's aim to get a lot of money, right? So because they look at it as skeptical, they are obviously looking at vaccines as untrustworthy, and therefore it's more important not to build transparency, to give more AFI data, to also align to their personal goals of vaccination and move towards more like community-oriented people that they trust to convince them that they should take this vaccine. So basically, we're looking at a vaccine strategy that takes into account all these various barriers in different ways and goes to various aspects of the population. And there are certain demographic aspects and certain attitudinal aspects to identify these people. And the last aspect that I want to touch upon real quick is the idea that these personas are also very dynamic, given the dynamic context itself, right? So when we went into the field in the start, we actually saw a lower risk perception because it was Jan. It was almost a vaccine discovery stage where I thought that everything was going to be better. The decision to take the vaccine was slightly more ahead in time versus when we went to the field during the second peak where there was an increased risk perception of COVID. But again, right, there was an increased politicization. There was a reduced trust in the government. There was also an increased presence of these lived experiences of side effects that a neighbor had taken and got like a fever for 8 days or someone had died. These unbearable side effects and these adverse events were really creating a deterrence to actually get vaccinated, and also an expectation discrepancy from people around them who got vaccinated who suddenly got COVID overall, right? So it's not just about risk perception, but it's about even the dynamic context of how stories actually go ahead, and also coupled with the fact that there was no communication about these adverse events, etc. So we actually see a movement, right? So we see people from the confused and the complacent who, because of high risk perception, kind of move to being more vaccine confident. But we did see a lot of people from the confused to become more nervous. Now, they were more scared about the implications on themselves because of the stories that they heard around them, or certain complacent people believing that the vaccine is going to really take away the control that I feel in my life, right? Suddenly I won't be able to go to work. I won't be able to care for my family. And therefore, you see people actually moving towards getting slightly more hesitant, but you also see the movement because of the increased risk perception towards getting the vaccine.
Great. Thanks so much. That was super interesting. I see there's another question on some more detail. I can share that Final Mile will be able to share this presentation for anyone who's curious. So please write to us at hello@coordinate.in and we'll be able to connect you to Final Mile. That's absolutely possible. Over to Paromita from SEWA Bharat.
Hi, everyone. Thanks for having us here. I'll be presenting a little bit of this research that we did, and I'll present the findings. I'll present the structure, and then I'll come back at the end about conclusions. But Sabah Ahmed, who goes to be in the research team, will talk a little bit more about the findings. So, SEWA, our research study, we primarily did it to figure out how to shape our reflections, shape our relief work better, to try to figure out where we need to be doing more work actively. Our sample was across these 9 states where we do intensive work. We surveyed 1,500 women, and we conducted about 15 FGDs. These represented all women from the informal economy across a variety of trades. And our data collectors were our frontline workers themselves. These are our Agevas and our community leaders who have been leading our relief work, and who have in the recent, especially in preparation for the second wave, who've picked up a lot of the healthcare work that we'll be doing, or that we have been doing when it comes to teaching people how to use oximeters and all of that. So this is our, so the research question, as I mentioned, it is targeting just figuring out what the concerns are about the COVID vaccine, what are the myths, so that we can design our IC materials better and plan our work better, and what are the concerns. And this is specifically concerns that women informal economy workers can have. And Sabha, over to you.
Thank you. I would just like to speak about the experiences that we had from the field and some of the cases that were a cause of concern to us. Vaccine hesitancy, while it was higher during the months of March, and then when the second wave hit in April, vaccine hesitancy seemed to have dropped in at least the urban elite, because people thought that there was a heightened fear to their loss and they could lose their lives. But this heightened fear was before us privileged people. For most people in the informal sector, this fear of losing their life is omnipresent. So for them, they continue to believe that their lives are dispensable, that they are dispensable as people. They are so at the bottom of the pyramid that they don't feel that they matter. And this is a feeling that the communication for clarity for vaccine, its necessity, the side effects, the possible spectrum of side effects, that should have come from a timely manner from the authorities in power, because behavioral change cannot be facilitated overnight. Of the 1,500 respondents that we spoke with, in the states of Rajasthan and Punjab, we had almost 50% people say that they would not take the vaccine. They were completely hesitant, and then 50% people said that they wouldn't take it. 1% people in Rajasthan, the women that we spoke with, said that they would want to take the vaccine. Of the total sample of 1,500 people, only 17% said that they were willing to take the vaccine when it would be available to them in a center or in a school or in a hospital near to their place of residence, because traveling far for a vaccine is also something that was not feasible for them. In terms of the challenges, one of the biggest challenges is the COVID portal itself. The COVID portal is meant for an English speaking. It's not in other languages. Smartphone using audience who can pay for expensive data packs, because walk-in facilities are too scattered and they are too few. I mean, if you ask me, in a way, we've ended up making a Tatkal ticket booking process on IRCTC, where even somebody like me spent almost 2 days trying to get myself a vaccine slot. This is a luxury that people, the women especially of the informal sector, do not have because of lack of access, because of the digital divide, and because they simply aren't aware enough of how to carry out a booking process, because they've not done it before. In terms of the challenges, another challenge that we have very recently, this is just 2 days back, and I was speaking with Paromita, my manager, today about it, of how the government had released one report where there is a conversation around 2 people having died from vaccine related side effects. When the moment it came out on the WhatsApp groups of the state teams, this was an article which was buzzing. And there was so much conversation that had to be done within the field mobilizers, with the staff, with the team itself, about what are the possible side effects, what it means, and how do they understand this piece of information. So the deterrent that one of the biggest deterrents has been just not clarity enough about what is it that the possible side effects could be. Different people have had different side effects. I personally had brain fog, which is something that if somebody, Paromita had heart palpitations and high pulse rate. So everybody responded very differently. But for people like us, having the education, the level of awareness, and the access to facilities made it easy that we were able to deal with this, and we were able to understand what was happening to us. In the informal sector, the loss of work, the loss of functionality in their bodies, even after taking a day or two off after the vaccine, as well as not knowing people personally who have taken the vaccine and survived, is a major deterrent. In Munger, which is one of the districts we work very, very intensively in Bihar, when we were carrying out the vaccine study, there was a lot of talk amongst people in a particular block where they said somebody we know died. When we tried to trace this somebody, that somebody was not found. But despite us trying to locate this person, we were not able to find them. When it comes to fears and insecurities, merely talking down to people for the lack of scientific acumen does not help, especially in the informal sector. It requires an empathetic approach grounded in kindness. And this I do not see as an idealistic person, I say this as a pragmatic person. To say that ignorance is the only reason for vaccine hesitancy will be unfair. A lot of it has to do with spread of misinformation, not just via digital but also print media. In this case, WhatsApp is a big culprit because of the speed and the reach it has. Paromita, you can conclude.
Yeah, so just to talk about these things when we are moving forward, as I said, we are doing this to try and figure out how to make sure that our members are able to resume work and are protected to the best of their ability. So some of the things that we have seen, this is what we're seeing working well for us, is the impact of peer modeling. Having women that you actually know in your community having taken this vaccine and survived it is something that is working. So like we've seen this in Punjab, for instance, some of our community leaders, two of them got the vaccine, and then the curve after that just became like our leaders started getting vaccinated a lot quicker. Registration camps for us have proved to be super effective, but trying to figure out how to set these registration camps up is obviously a challenge, right? Because you want to make sure that people don't get COVID coming to your registration camp for the vaccine. But at these camps, having someone sit with you, because people do have a smartphone and have like basic internet, we're trying to figure out how to use the COVID portal. So looking at so people just sitting there, looking at technology and digital barriers, also is a way for them to sit there. So we have our Agevans and our health workers lead these registration camps, so they like help explain myths and fears over there. And then vaccine drives. One of the big concerns that we've also seen is trying to figure out how to get people to vaccine centers and to get vaccinated. It takes a lot of time. It takes up days of work. So helping them arrange for childcare, helping them arrange for transportation, and then logging with employers for PPE. Yes, so everyone, just last thing is teleconsultation. This is something that everyone is looking at right now. We will get back to you about, we will get back to coordinate about a research around teleconsultation. This is something that we are currently working on. So that's our next study. But yes, Rohan, thank you.
Great, thank you, Paromita. At this point, I'd also like to just quickly say a welcome to our colleagues from the Immunization Technical Support Unit who joined us, led by Dr. Vansi Mathur. Welcome. And we're really grateful that you're here. We'll also get time for an actual exchange, but I'll quickly move on to Diksha and Pooja from CSBC. Over to you to share with us your synthesis.
Great, thank you, Rohan. I'm Diksha Radhakrishnan. I'm Deputy Director of the Center for Social and Behaviour Change, which is a behavioral design and research center looking to see how we can apply behavioral insights to solve policy challenges. So since we have limited time, I'm going to kind of jump right into it. So what is it that we are really going to present? So we've seen some great studies being presented, and the kind of what we are really going to bring here is to bring together a synthesis of all the different barriers and drivers of vaccine hesitancy. So the idea is to see what all the different kind of discussions that have come up in the past, presented by the other partners, and looking at other literature and anecdotal evidence. What is the long list of barriers that we maybe need to be focusing on for solving this extremely pertinent challenge in front of us. And the second kind of part of this presentation will also be about discussing some of the gaps and limitations that exist in the empirical work around hesitancy, and how can we really move forward to kind of expand this entire work so that we can learn better to make better policy decisions as well. So yeah, our methodology is pretty simple, looking at all the data that's available, empirical and even anecdotal data in terms of like media reports, which is coming out almost on a daily basis, and also looking at the applying behavioral insights to understand the larger space and how decisions around vaccine uptake is done. I think this has been stressed enough in the previous presentations, but doesn't hurt to repeat once again at how important it is to kind of emphasize that vaccine hesitancy is best understood as a spectrum. This is extremely important, especially from a measurement point of view as well, so that we don't look at this as a binary concept even when measuring it, but really think of it as a continuum. And even when we measure, we need to look at people across the continuum, because even if people are responding like positively, but without, they could still be expressing elements of hesitancy. So it's important to not just look at them as who has said I will go and take it and who hasn't, but understanding even within those lines what are the different grouping of people. So we're now kind of jumping into the first part of the discussion on what is looking at the synthesis of the barriers that we kind of outlined in terms of vaccine uptake. For the sake of kind of consuming this information, we've categorized this under four broad areas. One is looking at trust. both in the vaccine and around the vaccine. And this is a very important bucket, as we've also heard, that this itself is kind of one of the big areas where vaccine hesitancy kind of creeps up. Then there's also the issue of uncertainty around the vaccine access and how that kind of plays out in terms of hesitancy. And then both beliefs about COVID in general, and then even other past, even in beliefs, more general beliefs and past experiences, and how those kind of also impact the way we think about vaccines. So going into each of these, so starting about trust. So trust is one of the things which has multiple layers within it, and just to unpack that itself, that there's so much to kind of understand around this. But how we are really looking at this is that there is firstly trust in the vaccine itself, right? So the COVID vaccine, the way that it is structured operates a bit differently, where it doesn't eliminate infection but reduces the infection load, right? So this becomes a very difficult cognitive concept to explain to people. So then there is that sense of, if I'm going to still get the infection post the vaccine, that means the vaccine is not effective. So how do you convey this very scientific kind of aspect to the larger population and explain it to them in a way that it doesn't mean that the vaccine is not effective? So this big concern around how whether the vaccine itself is going to help prevent COVID is still a question that is floating around and leading to a lot of hesitancy in itself. Related to this is the issue of side effects, which a lot of people also have spoken about. And here again, the concern comes up of side effects in multiple ways. Firstly, it's in terms of your own health, and like, okay, am I going to have suffer from other health issues because of the vaccine? But then also it is a concern of other losses, economic loss or other losses which come from the idea of fearing side effects, right? A big issue of also this, as I think the partners from SEWA Bharat were talking about, is this issue of what we would call availability bias, right? The stories of the adverse effects of vaccine is the one that gets most amplified, the one that gets passed around, and then that's the one that sticks with people longer. So then how do you kind of address that when there is, the stories of people not falling sick are not as fun to share? So then how do you really look at that, and how do you kind of bring that greater understanding of the probability of having side effects from vaccine versus the probability of not getting COVID because of getting the vaccine, right? These are again very complex kind of terms that we're trying to convey, and here again, since those are not easy to convey right now, this is becoming another big issue for vaccine hesitancy. And then of course related to that is the fear of possible deaths, related to again the kind of media reports that are coming out around this. Then if we really look at what is trust around the vaccine, right? So here what we can see is that there is this concern of how the vaccine itself was developed. And there is a sense that now there is a current understanding that vaccines take much longer, there is a lot of testing, and that there is, it goes through a lot of approvals before it can get released. So the way that the current vaccine has come out, leaves a lot of concern among people as to why, whether this is too rushed and whether this has been done in a way which is not actually leads to safety. This is again what we might call the issue of status quo bias. You're used to a particular way, but we are living in a very different world right now of a pandemic where, of course, a huge amount of resources have gone into this vaccine development, but that moving people away from that kind of concept of this is what was there before a pandemic to now how it's being operated is not an easy kind of journey for people to make, which then leads them to think that this process itself is not a safe one. Added to this is also the issue of a lot of growing mistrust among the population towards the government and towards other institutions related to the government, right? So there's this cumulative mistrust that gets adding up, and then because these lines and these there's a lot of merging of lines between the different units of the government, whether that is who is the manufacturing unit, who is the processing unit, who is the frontline health workers coming to mobilize me. All of this kind of gets together and be seen as one big government unit, and then there isn't that understanding that maybe some units are that there is that your mistrust which comes targeted from some other experience is targeted to one particular aspect of the government, but that kind of translates very easily back to thinking about this whole government and everything that, that they're out to get me and that they are not really concerned about my well-being. Of course, the recent events, the second wave has also exacerbates the situation in the sense of feeling already that you're alone and you're not sure if the government is really kind of supporting your needs. Moving ahead, we can also see that the other big concern is around access to vaccine, and here this becomes a major. This again is layered in almost thinking of it in three ways, right? One is how easy is it for me to actually access the vaccine, and we've heard a lot of instances, and maybe we've all also experienced it, of how difficult the registration process has been, and even in terms of accessing vaccination centers. And what this leads to when we're looking at making a decision of getting a vaccine or not, this kind of increases the cost factor or the of getting the vaccine, because not only are you maybe concerned about side effects, you're also now taking into account the inconvenience factor, the cumbersome of going through that entire process, whereas the benefit then might seem very small to you, especially if you're someone who's anyway concerned about the efficacy of the vaccine. This especially kind of could play have a big impact in terms of who we would call fence sitters, people who are maybe somewhere in the middle of that vaccine hesitancy spectrum, who would maybe attempt to get the vaccine, but if there hasn't been an immediate reward in their effort to get the vaccine, then there is a tendency for them to kind of give up more easily, right? What we might call the sour grapes syndrome. If it's too difficult, then maybe it's not really worth it. And that could be a big driving factor.
So yes, I think Diksha covered most of the points here around uncertainty, around vaccine access. But even the sort of choice of 2 or 3 vaccines in some cases could sort of lead to this choice anxiety. But also it could lead to a just sort of a sense of unfairness around sort of the vaccines that are available across geographies. So these are some of the sort of conjectures also that we've drawn from Behavioural Insights around how just vaccine access could lead to hesitancy. So then around beliefs around COVID-19. So I think this is something that has also been touched upon in terms of just misinformation out there, but also in certain groups, there's this belief that COVID-19 isn't even real. This sort of gets fueled by certain social media groups. I think we've been seeing media reports around this. And then the other point is around low risk perception of COVID-19. I think this is a point that was sort of brought into question during the second wave. Is this even valid after the second wave? But it could be a valid sort of barrier among those who have perhaps made it through without severe illness of COVID-19, and leading them sort of believing that, there's this sort of invincibility that comes from it, and therefore this sort of belief that the vaccine is not required. And then the last point here is really about, so much has happened during the pandemic. There's a second wave that has happened, and after all of this, the vaccine just feels like a futile effort. So sort of these beliefs around COVID-19 also fuel hesitancy.
Coming to the last kind of section of what we see as further barriers on the vaccine uptake is also looking at past experiences, right? Like I think this was also mentioned by panel 19. Adult vaccines are something that are not very familiar to people, and the ones that are, like the tetanus or the rabies vaccine, also have a trigger. They're more curative in nature than what the COVID vaccine is. So this is really a very different experience for someone, or a very different type of decision making. There isn't a trigger per se to go get vaccinated. So how do you even take into account, it's completely a different kind of playing field for people in that sense. And then added to that, there could be a growing fear of needles that might also exist. There isn't very strong, it's relatively an unexplored area, and it's not strong evidence, but a lot of the fact that there is like literally a jab, and again goes back into this ideas of mistrust with the government or with fear of side effects. The fact that it's like, the intrusive part of the exercise could also be a specific factor. More broadly is this idea of fatalism, which we think could actually play a big aspect in terms of, especially since the fact that there is this pandemic that we've all been living through, and a sense of like a futility in taking any kind of action towards it, right? Like this is all predestined, and there isn't really a need to make any further effort on this to kind of save yourself. So this could also be, especially the second wave, and seeing the kind of deaths and suffering that has happened, might just lead someone to kind of just take a step back and be like, this is really not something that we need to go for. So now that we've kind of outlined this long list of barriers that we think could be playing a big role, if we really look at it now, how do we kind of think of all this empirical work that is out there, or how do we really take this further? Some key things we do want to highlight upfront is when thinking about the barriers of vaccine hesitancy, we do really need to be clear that these barriers are not mutually exclusive. So that's, even though the way that we kind of listed them out might seem like so, because they are highly interdependent and contributing to each other. And this especially when we are looking at stated responses, this might be a big challenge in how we measure as well, because people might not be great at explaining the reason for hesitancy, and hence we should also be taken into account that a stated effect of saying side effects might not in any case only mean side effects, but could be so many underlying aspects playing into that. There's also, we see a high variation in how vaccine hesitancy is measured based on the kind of questions you ask or the sampling that you look at, or the kind of groups you come in. So it becomes really difficult to reconcile all of that. And there is a need to kind of see how we can bring in some of that together so that as we are taking efforts to do this activity across various regions, how can we at some level bring some standardization to help us reconcile all of this data. The third aspect, I think, again, something that has come up previous times, of course, barriers are not static in nature. They're extremely dynamic. The world we are living in is constantly evolving and changing. So there is a need to kind of also think of these barriers as evolving and changing and understand that different times, different barriers might be really pushing hesitancy. Then if we look at also the more specifically the empirical work that is there right now, there are certain limitations in that. And firstly, that of course a lot of the work is still very urban based, and this comes from the fact that we've had to rely on social media and remote research methods because of mobility restrictions. But there is now a real key need to build our understanding of rural and low income populations and how do they understand hesitancy and understanding the way that the environment within which they are operating. Need to also explore other non-traditional reasons. There is a sense to constantly look at trust or side effects or even the cost of vaccine, but also need to looking at all of these aspects which might really be underlying factors, and addressing those could help in the longer run. Then, of course, looking at supply side factors a lot more. These are like low-hanging fruits because there is greater accessibility to changing this kind of barriers more easily. So how do you we need to identify and understand how much of these are really affecting hesitancy, and then really looking at how we can address those more quickly. And the last thing, an extremely important point, that a lot of our understanding on vaccine hesitancy is still specific to the first dose. A whole different type of hesitancy can start playing in when we think about coming back to the second dose, and that is still quite an unexplored area which needs further investigation. There's some ideas about how we could take further empirical work forward in terms of thinking more innovatively about techniques, about trying to do more mixed method work, trying to bring standardization in our tools, and then of course there's a lot of need to balance speed and rigor because decisions need to be made immediately. So how can we kind of build empirical evidence in a quick way to help inform that? And lastly, as I said, thank you.
Thanks so much, Diksha. We maybe take a pause here and check in case there are any sort of overarching clarifying questions that anyone has. I know we don't have enough time to go into a wider discussion, but in case if there's anyone who has quick questions for the CSPC team or any of the previous presenters, please feel free to unmute yourselves and ask.
Rohan, if I can very quickly ask, my name is Geeta Trivedi and I'm from UNICEF. I just wanted to check with Diksha. Did you also look at health providers as a separate group to understand, what are their behavioral patterns versus the community who obviously have much lesser information than health providers?
No, that's a great question. I think there was one study that we looked at, which was with medical students, which is referred here, which does talk about how even for them, when, as such, with the survey which was done with medical students, it showed that there was still very high hesitancy among that group, especially concerns around safety and efficacy around the vaccine, and that only when they were able to look at increased risk perception of COVID, whether by looking at seeing increased caseload, only then they did show a declining trend of vaccine hesitancy, right? That was one of the studies kind of pointing towards a service provider that you would expect that group to be more forthcoming with the vaccine, but they also show very similar kind of behaviors as the larger community. But more than that, as such, there hasn't been a lot of work, at least we've not been able to look at a lot of work on the frontline health worker side of things, but definitely it's an important group to understand, especially if they are going to be the mobilizers to get people to get vaccinated.
I see there's also a comment by Devamitra around this, and I'm wondering if Devamitra, you want to come online and just speak to also Himanshu's question in case if you have any thoughts on that already around just door-to-door vaccination and feasibility, and from your experience how these states have been able to manage that.
Thank you, Rohan. Hi, good afternoon, everyone. I'm Devamitra from ITSU. Yes, but before this, I have a question, and I think that it was pertaining to the gender. It was my question. We had a presentation on women informal economy. I think it was done by SEWA Bharat. So like I was about to ask that, was a question been asked that how much decision-making agency they are when it comes to vaccination? So do they take the decisions for themselves or have to depend on the male members of the family, like the father, father-in-law, or in many cases in rural or tribal areas, the in-laws and the sister-in-laws, they play a huge role when it comes to decision-making. And I'm talking about the mothers or the like young mothers I'm talking about. So this was my question. And coming back to your this super spreader, the vaccination initiative taken by West Bengal is that it is a state initiative and it is adopted by a few of the states of India. Like they have done the vaccination on wheels because in the process, they're actually addressing the issues of vaccine hesitancy. They've hired a large bus, and they're going especially for the rural pockets which have tribal population, those hamlets. So they're going to every village and not where in the village, like in the marketplaces, the crowded areas. And already the line list is with ASHA. They're calling out it's like hassle-free because we know there is a digital divide in the rural area. So many people, they do not have access to smartphone, and those who have access to smartphone, they are not being able to register on CoWIN. So address all the issues because gradually what is happening because of this digital divide, maybe this group who are eager to avail the vaccine, they're gradually turning into vaccine hesitant group. So this vaccination on wheel is not only catering vaccine to the doorstep, but also addressing the vaccine hesitancy in the process. Thank you.
Thank you for that sharing. Very quickly, if I can request Paromita to respond to that question.
Yeah, just a quick response to that. It is actually the sample we did ask about the decisions, who makes the health decisions, do they feel comfortable making the decisions themselves? And these were being asked by community leaders, or people that they have a rapport with. The sample is pretty much split across a couple of different options. Some where the men in the family or whoever's considered the guardian of the family are taking it and the women aren't for a variety of reasons. Sabha has mentioned some of them in the chat. In some cases, the women were perfectly comfortable taking the decision on their own, and in some cases they were deferring to men. It's actually almost pretty much equally split across these three.
Thank you, Paromita. I also recognize that, I mean, as the CSBC sort of presentation pointed out, that we actually, there's so many of these things, and it's dynamic and it's complex. So I guess there are multiple more questions that continue to follow. Maybe what we do is now take the time to go over to Monk Prayogshala, and we have Anirudh and Hansika with us, who've been working on a tool and have deployed it also, and we'd learn a little bit about the process of making this tool and what's come out of it so far. Over to Anirudh.
Thanks, Rohan. A lot of it was motivated by some of our past work in COVID-19 behaviors in India, and sort of now beginning to look at the vaccination sort of attitudes and knowledge and perceptions related to vaccination. And of course, as we've seen from your presentations today, there's been a lot of heterogeneity in the drives, and there's large fraction of people who have gained access, and many who have already been vaccinated as well. So studying vaccine hesitancy and sort of attitudes towards vaccine is kind of a important thing to be doing right now. So part of our earlier work on COVID-19 is focused on understanding sort of intersections between behavioral economics, social psychology generally. So we were looking at, which Hansika will talk about later, is looking at things like moral emotions, conspiracy theories, not unlike the things actually that came up in the CSBC synthesis. So, and also looking at some of that data helped us understand a little bit more about some of the variables that could be as well. So information sources kept coming up as something that seemed to be kind of significantly associated with vaccine uptake in that sense. And we wanted to extend that to study a couple of other things that could directly speak to public health messaging in the Indian context. So, trying to understand what kind of messages can we frame and how can we perhaps deliver them. So, thanks to input from Priya and Shekhar, we kind of put together like a short survey. And essentially, we've been collecting some data on this since the past couple of weeks, and we have some measures that we'd like to show you. And this is sort of preliminary work at this stage, and we're also looking at support to sort of, if anybody's interested in collecting more data with us, in case any of these tools are of interest. And of course, the outcome that we expect to see as a result of this is to kind of look at public health messaging and all these things. Thank you. So yeah, just some basic questions on sort of whether, how we measure things like willingness to take a vaccine and hesitancy. Part of this comes from our earlier survey with our colleagues at Bias, where we found that the hesitancy seems to be largely comprised of things such as concerns about side effects, ingredients, as well as the cost of the vaccine. And we include sort of one question here on role models in it, because we were trying to also understand if there's a potential for looking at messengers, sort of the role of messengers in terms of delivering vaccine-related messages. So this is just a list of people, and of course, this was we came up with this sort of before the Prime Minister got his vaccine, but we were sort of looking at how that might depend on what people consider to be important for taking the vaccine.
Thanks, Eti. And what we also did was adapt some of the work that we had conducted earlier in the year on the role of moral emotions and mask wearing in more general preventive health behaviors such as mask wearing, hand washing, etc. And moral emotions are emotions such as contempt or gratitude or pride and shame and guilt. So they can be other condemning, other praising, self-condemning, self-praising, and they actually govern how we judge other people's behavior from a moral lens. And we found actually in our past work that moral emotions, both negative, such as the ones on your screen, as well as on the next slide, moral emotions that are positive, both governed whether individuals were likely to wear masks. And therefore, we wanted to understand whether moral emotions are something that could help explain whether individuals are willing to get vaccinated and how they perceive other people who get vaccinated and how they perceive themselves for getting vaccinated. The other thing that we wanted to look at is where individuals get their information from about COVID-19, about the COVID-19 vaccine as well, because past research again showed that this has an impact on whether an individual is going to say that they're going to take the vaccination or not, as well as how quickly they are going to take the vaccination. And I think on the next slide, there's also trust related to various sources and various individuals, wherein we wanted to understand both from a very immediate circle, social circle, to a wider social circle, how much individuals trust these various stakeholders in society and whether that has an impact on their preventive health behaviors, such as vaccine uptake. So this is a snapshot of the items that we have included in the survey. Again, it's really short. We wanted to deploy it as widely as possible, available in both English and Hindi. So I suppose in case anyone is interested in collaborating and taking the survey forward, please let us know. We are also actively looking for getting a project like this, as well as insights from this project, to feed back into larger public health communication funded. So if you are interested in collaborating, probably writing a grant together basis these insights, please get in touch. Thank you.
Great, thanks so much, Hansika. Any quick questions for Hansika, Anirudh? Any reflections on the tool itself?
Hi, I can ask a question. This is Divya from ID Insights. Hi, Hansika and Anirudh. I just had a question on this tool. Have you tested the validity of it in any way? Like, have you correlated it with actual, people's behaviors in terms of, does the emotion actually predict what they go on and do?
Hi, Divya. Thanks for your question. So, based on our past research on mask wearing and moral emotions, we have actually validated it. We've done confirmatory factor analysis, and we found that there are these two buckets of other emotions and self-emotions in the morality context. And that study was also done with Indian participants. So it is a reliable and valid measure, which is why we kind of adapted it to the vaccine context. And from our earlier work, I think there are other measures that we have used corresponding to people's behavior. So a lot of the questions in this are actually that have actually been deployed in an earlier survey with another organization that we consult with, Bias, and which is why we wanted to kind of extend that work. And it is, I would like to say about 60% of the questions are ones that we've already used in the past.
I think Priya had a request, and mine was a similar one, I guess. Hansika, Anirudh, could you give us a sense of the cohorts that you think would be most relevant for a survey like this? Are there any particular demographics or geographies you had in mind? What have you tested this on? And in case, as it goes further, what would be target areas to look at?
Sure. Yeah, thanks, Priya. Thanks. So we were initially sort of looking at the younger age group, which is basically broadly between 18 to 24, but I think at this stage, and sort of following all the insights that were shared earlier as well, I think it's important for us to carefully sift through cohorts that have not been vaccinated yet, of course, first dose as well, and try and understand what their attitudes might be. And I think looking also at more. So given that at the current stage, the way that the survey has been rolled out, it obviously reaches only sort of a very select group of people. So we would obviously like to reach out to also individuals residing in smaller towns and cities, people who have typically are, like I said, get to get vaccinated 18 to 24. And also earlier on, we were looking at potentially at individuals who might serve a primary caregiving role within the family. And I think what Shantanu was saying earlier on about how females are now increasingly getting vaccinated, I think that that's sort of very, very interesting. And I think we definitely like to look at some of these attitudes, these measures in that context as well. So I think that broadly gives you an idea of looking at sort of younger people who haven't been vaccinated, people living in sort of smaller towns and cities. But at the same time, we are completely open to talking to people, figuring out what kind of cohorts they might want to look at as well, and sort of potentially also even adapting this tool a little bit. And also, of course, rolling it out in multiple different languages. I think at this stage, we've restricted ourselves to a very small minority in terms of languages, as people who can access this survey online. So we definitely like to also expand that.
I have a message from Shekhar that I'm just going to read out, and it says, given recent guidelines from the Ministry of Health to make vaccines available nearer to the elderly, opening up camps and walk-ins. If anyone has suggestions on how one designs community-based programs for vaccination, we'd be keen to facilitate that. Sorry, that was completely incoherent. Shekhar, would you like to just come in and share this?
Sorry about that. I was just sending it to you to see whether that was useful to collate. This is on a tangent, so I didn't want to break the flow. I just wanted to ask this group whether you have any feedback on barriers for or any suggestions on community-based vaccination programs, right? So how do you say at a village level, how do you design for decentralized vaccination program? If there are any specific suggestions, directions, we'd welcome that.
So in the group, if anyone has ideas on that, on community-based vaccination programs, to reach out to me and I'll connect you to Shekhar. I had one question to Anirudh, perhaps also on administering the survey. Do you imagine it to be self-administered on a digital platform, or can it be a phone survey? Do you have a sense of that? And does that change? Like, do the questions change? And what did you try out so far?
Yeah, thanks, Prabhat. So it is primarily self-administered and primarily administered online. It can be taken in both, like a laptop, tablet, or a phone, or anything. So yeah, ideally that's what we've done so far. And again, it's been, like I said, so we do have, because it's a fairly short survey, there has been like about 750 plus responses or so far. But we haven't really sort of tried doing it in say through administered, say, via an enumerator or anything. There is some, of course, then there's some scope for social desirability and sort of things like that when people are responding to. So we have questions about moral emotions, right? So when we ask people, like, do you feel angry about this? Like, it's likely to have some element of social desirability, which we're not able to perfectly gauge in this format. But yeah, thanks for that.
Any other sort of offers? If anyone has ideas of populations to work with, cohorts that they're already working with that they think will fit well with, or maybe it's too preliminary a question to ask. But
yeah,
if there are any
feel
ideas,
free to connect with us. I mean, the slide that we spend the longest on is our email addresses. So feel free to write to us anytime. We'd be happy to discuss and also share, even if needed, some of the preliminary insights that we've got so far.
Great. I see there's also Nandita here from Faculty in Facebook who says that if there's anyone designing effective communication campaigns, which I know there's a few who look at that and get to it. So please reach out to me and I can connect you to Nandita. Priya, do you want to share something?
No, is Tej here? Tej is coming in?
Yes, Tej is just joining. We have about 10 minutes for Tej, so we have about 3-4 minutes to go. If you want to
share. He hasn't joined us yet. Oh, yeah, no, I was thinking that we should invite him because I'm afraid people may drop out, and I definitely want to hear from him. Just from my perspective, I would say, well, thank you, everybody, all the presenters. I think going back to the essence of CoreNet, on principles on which it was founded, I think there is some element of standardization that we would still want to continue to aspire to, and mostly in the measures. So, Divya and others, like I think Divya, you asked that question and appreciated it. So I think much more as we go into second or third wave of studies, can we begin to start thinking about what kinds of questions different people have asked? Albeit I understand samples are different, but still, are there ways we can standardize tools and questionnaires and create maybe a little bit of a bank of questionnaires? And there, I think CoreNet can also help with creating that and maybe looking across the categories. One is that. And then the second is the other principle on which CoreNet was founded was around synthesis and non-replication. So I think this sharing is really important because you know who's doing what, and therefore, if we collect more data, we should build on whatever is already collected. And CSPC is doing synthesis, so that's available, I think, now to the group. But we've also heard each other, so we know that there is potential to build more synthetic work amongst the community. So those are the only 2 points, Rohan. And I welcome Tej, and I'd like to hear from him now.
Great. I'll pass on to Tej now, but in case if anyone wants to access any of these studies to go through in detail, please reach out to me. There's a common Google Drive folder that we've set up where all of these PDFs exist. So we'd be very happy to share them with you. Over to Tej.
Hi, so I think this is just a slide to show like the amount of confusion around the price of the vaccine. When the whole process started, and still we're not very sure about what's the price that one of us is going to pay if we're going to take the vaccine. So what we thought was to run like a not exactly a survey. I mean, one could call it as a survey, but more like a citizen science project where we wanted to collect like a vaccination cost data. It's an ongoing project. We have about, I think around 1,000 samples, I think roughly collected. Currently, we have not released it yet, but we're planning to release it. And it mainly captures, vaccination date and vaccination type, which is like one of the brands of vaccination. Age bracket, which is, less than 45 or more than 45, and cost including everything, whatever the hospital charges you. If they charge you like 150 rupees extra to, register at the hospital or whatever they ask you to do, the overall cost. There are 2 where clauses. One is, which PIN code, whether you or the hospital where you took belongs to, just to place you geographically. And the second where clause is like actually what kind of facility you use to actually take the vaccine. Which is like in case of private, it could be a private hospital or, but booked through your apartment, because the rates could vary based on these categories. Like if you're booked through apartment, it could be a different rate, or if you provide it to an employer, which could actually, most of them, have entered private hospital employer, and it's zero cost because someone else has funded it. So that's why we wanted to capture this data, and and some of them are like entered by the people themselves. This is how actually the data set looks like. We're going to open it up for public consumption. We are not like a research institute. Just to give a background, I run a community called DataMeet, which runs an open data related community, and we've been doing some work around COVID from this beginning, mostly archiving data and stuff like that. So this is how the data set looks like. It's fairly clean. By month end, I think we should open up the first set of it for any of you to explore and anyone in the world to explore. And actually, that's it. I just wanted you to introduce to this data set. So if anyone want to use it, I'm happy to share it. And actually, it will be open on the web, so you can share it. And it falls into the same category that we did with the other 2 data sets. One was, I think, around lockdown deaths. They were more like an analysis of media and collection of data, both lockdown deaths and voter shortage deaths. But this one is more like a crowdsourced data set. A little bit different, but in the same category. All 3 are like available under CC by SA if anyone wants to use it. Actually, that's it. I'll probably share the link when we release it, so you guys can use it. And if it helps in any of the other studies as a supporting data set, I think I'll be more than happy about collecting this data set.
Thank you, Tej. Just a quick question: how many entries do you have already on the crowdsourced one for vaccine cost?
I think it was about 1,000.
We already have 1,000 from the survey. Okay, great. And it's still ongoing. So if you drop the link here, everyone else can take it and share it, right?
Yeah, and it's one row per vaccination take, which means if you're taking 2 doses, it's 2 entries.
Shekhar, Priya, any questions?
I mean, others may also have, Rohan, but I don't understand fully the methodology take. So how much data do you need of like these kind of responses to kind of say, okay, this is reliable data, you've kind of touched a large population and you can make sense of it? I mean, from what I understand is, and then like every person is only putting information once. What if they come back repeatedly? Are you getting the same person's information responses multiple times? Like, how do you check for stuff like that?
There are a couple of ways to answer. That's why I didn't call it a survey, because it's neither randomized. I can't guarantee some of the things. That's why it's mostly called a crowdsourced data set, and it does come with its own faults. That's something to consider before one starts to using it. I think even on the page we mentioned what are the shortages of collecting a data set like this. And the second part as to how do we make sure there are duplicates, there are a couple of ways to identify. One is, I think, are there like any random spike in the thing? More like on the technical side of analysis, like whether on the timestamp there are randomized things, a random increase in the number of submissions and stuff like that. But other than that, I don't have any other way to tell you this is like 100% accurate. The other thing that we initially thought about was asking people to submit the bills itself, but that would have been much more painful, not to analyze or make a data entry, but to take the responsibility of protecting someone's privacy. So I think that's where we shifted to a generic crowdsourced data set.
Rohan, I don't know if others have. Shekhar, do you have any questions or?
No, thanks to the presenters. Really nice to hear everybody's perspectives. And I put my last closing comment on the chat. I think we have to address the issue on a temporal basis. Right now, hesitancy is shrouded by supply issues. The hesitancy might flare up a little later when supply opens. And then when different kinds of vaccines enter the market, we might have to factor in vaccine preference or brand preference, leading to certain, like Diksha pointed out, choice anxieties, whether you hesitate to take one over the other, whether one is not available, you delay vaccination, etc. Those are not burning issues now, but it might come up later. Thanks a lot from my end to everybody.
Thank you, Shekhar. One quick question for Tej from Himanshu.
Yeah, I'm very curious about the crowdsourced data, and I think it would be nice to learn a little bit more about it. As you get responses, would you be able to share a slide or two with Rohan? I think he can share it with us.
Sure, I should be able to share.
I think really looking at the price, or are you looking at willingness to pay, opportunity cost, like Himanshu's asked on the chat?
No, I think it's just the price. I'm not.
And you imagine that now that the government has regulated the price to some extent, you'd still see a lot of departure from it in reality?
I don't know, but maybe we will see. But yeah, your final price is something that actually hospital charges you, because even though, let's say, the vaccine rate is 400, and then there is handling charges of 150 rupees or so, and then there is hospital registration charges of another 200 rupees or so. So we're asking them to add up all those and put it as a vaccination cost, not just the cost of the vaccine dose itself, the whole cost.
Thanks, Tej. I see we have a hand up from Govind Agarwal. Govind, if you could introduce yourself and share your thoughts on the question.
Hey, hi. I'm Govind Agrawal from NCAER Digital Runners. I joined this call pretty late. We are doing a big project related to vaccine hesitancy called Project Suraksha with funding from India Crypto Relief Fund. And I wanted to see if this community can help us in expanding this project, where we are doing 1:1 counseling of villagers in rural India, meeting them one by one through our large network of digital runners who go and meet people, collect their data 1:1 on our mobile app, and then we ensure that they actually get vaccinated by providing all kind of digital help which is required. Doing this end-to-end to solve vaccine hesitancy, and we are paying ₹50 for every vaccination which happens at the last mile. In phase 1, we are trying to reach to almost 1 million villagers, and overall we want to actually reach to millions of villagers, because India Crypto Relief Fund is very excited about solving this problem in a foolproof manner by 1:1 counseling provided by us.
That sounds great. Yeah, and I'm sure many people from our community will be willing to see and help and support and learn. So great. It's really why the community comes together. So firstly, thanks again to all of our speakers. Thank you to Govind for sharing that with us. Thanks to all of our speakers. We had Shantanu from NCAER, Anushka from Final Mile, Paro from SEWA Bharat, and then to Diksha and Pooja from CSBC. Thank you, everyone who joined us. Again, to Monk Prayogshala and Tej, finally. They're all CoreNet members, and to everyone from the community who was with us this afternoon.